So, well, thank you everyone for coming here this evening. My name is Ben Hechler, for those of you who may or may not know who I am from some of the publication for this discussion tonight. I'm a physician here at Duke University Hospitals in Durham, North Carolina. It's my pleasure to talk to you tonight about rural medical professionals and rural patients and how intraoral telehealth can be used to save time, money, and lives. And I'll tell you, even though the title of this presentation is with regard to rural medical professionals and rural patients, it is not unique to these patients that benefits can be realized with intraoral telehealth. It's just simply because these patients are a historically vulnerable population that a lot of the benefit from this is realized and keenly felt by this group. So keep that in mind as we move forward through this presentation, and I'll be highlighting a lot of ways that you can have improvement in your practice for both rural and urban settings. I want to start this presentation by briefly showing a photograph and then a video of an image taken on the TelScope Telehealth device of an oral squamous cell carcinoma in rural Australia, and how this was used as a life-saving device in this setting. And I want you to keep this in mind because we will come back to this here as we come back to the end of our presentation. So I want to first start out by talking about the age of telehealth currently and the status of telehealth in the United States of America. And I know this has changed a lot, of course, over the last number of years, particularly for those of us in the COVID pandemic era. And I think there are multiple things that have evolved over the number of years, but one thing that we can say that is here to stay is that telehealth is permanent. And I think this has been evidenced not only in many of our practices, but in some of the numbers and statistics that have been coming out recently. Some of these include the following. One is that over the next couple of years, it's projected that in the USA alone, up to $64 billion of an industry will be built around telehealth. And I think this is also evidenced by the fact that if you look at 2015, only 20 some odd states in the United States actually had third-party reimbursement for telehealth services. And as of this past year, at least when I looked last, this was now up into the mid-40s. And so the change in third-party insurance coverage that is required by law in states has significantly increased during the COVID pandemic, and particularly so over the last year or so. Now, many of you may be wondering how this applies to those of you who practice teledentistry. And teledentistry, to be fair, has been a little bit different than telemedicine. For example, some states, teledentistry is very well defined, and it actually is included in legislation and has been that way for quite some time. In other disciplines and other states, that has kind of been merged into and taken under the umbrella of telemedicine, teledentistry has. And yet in other states, such as my state of North Carolina, it has taken quite some time, and there are still some states that do not have a clear definition of what teledentistry is or how that can be used to benefit your practice. So, for example, in North Carolina, it wasn't until last summer that actually legislation was passed defining what teledentistry was and how it could be used in our state by dentists and dental hygienists, for example. That's even in a state like mine where 98 of our 100 counties are indicated by the ADA as shortage areas for dental care. So I do understand that with this uncertainty, people have been asking questions about how do I actually incorporate this and should I incorporate this into my practice? And so, many articles like this continue to come online. This was published just last month, questioning if telehealth will be just a passing fancy, particularly with regard to payment parity. Will we actually be able to get reimbursed equivalently for these services? And I understand that this has been a concern for many individuals, and I think it's important to follow the regulations. But I think part of this is simply that people have been asking the wrong question, quite honestly. I think a lot of people are asking the question, does my state allow teledentistry and telehealth? And will I get adequately reimbursed for teledentistry and telehealth? And I think that's the wrong question, quite honestly. I think the correct question to answer in this scenario is, how can I use teledentistry and telehealth to benefit my practice? And quite honestly, this question is a much more comfortable question to answer because this question puts the choice into your hands, into the medical provider's hands, the dental provider's hands, the clinician's hands, as well as the business manager and the administrator's hands. And this allows you to choose your own destiny with how you can use telehealth, specifically intraoral telehealth, to benefit your practice. So I want to talk briefly about the rural patient population in specific, since this is a highlight of this talk. And as I mentioned, it is not that intraoral telehealth only benefits this group, but it is true that being a vulnerable population, the benefits of telehealth are more keenly felt in this group. And regardless of if you are a rural or urban provider, many of us treat patients that come from rural areas. And so this really does play a role in many people's practice, including my own, quite significantly. So let's start with a few facts from rural patients. The first is that this group of patients are more likely to die from all 5 of the major causes of mortality in the USA. This includes things like stroke, coronary artery disease, such as acute myocardial infarction, injury, and cancer. Now, we know that many of these, particularly coronary artery disease, diabetes, and cancer, have a direct dental medical relationship. But even if we look at the dental care and dental status of these patients, we know that these rural patients have a much higher rate of dental caries and a full 2-fold increased likelihood of becoming completely edentulous. Now, it'd be very easy to say that this is due to habits or preferences or values of these rural patients, but quite honestly, that would not be supported by the evidence and the data that we have. And if you look at the data and if you actually speak to these patients, they will tell you that the number one barrier cited by them as far as lack of care is availability and convenience of those services, and particularly distance to those services. And I think this really gets at the heart of where telehealth and oral telehealth in particular comes into play. And this is the difference between healthcare equality and healthcare equity. And this has been a huge hot topic in the United States the last couple of years. And if you don't know the difference between these two, I would implore you to look into this, because I truly think with the way that reimbursement and evaluations of practices are going nowadays, I do think over the next couple of years, your reimbursement and evaluations will be based upon how well you achieve healthcare equity. So let me briefly describe these for those of you who may not be familiar with these. Healthcare equality is increasing the amount of resources and the number of resources that you give to patients and making that equal across the board. Whereas healthcare equity means that you are providing specific resources to specific groups of people that actually need them, and or removing barriers from specific groups of people that actually need those barriers removed. So for example, if I were to open my practice from 8 a.m. to 5 p.m., and I let any patient from any location, any demographic schedule during that entire time for any type of service, that would be healthcare equality. I'm providing the same options to patients. But if I implement oral telehealth into my practice, in my practice, I use the TelScope device. If I were to implement this into my practice, and therefore a patient who lives 5 minutes away from me is affluent and can afford to see me at any time he or she wants, and also a patient that lives 2 or 3 hours away in rural North Carolina and can't afford or doesn't have transportation to come see me, if I can see him or her as well, I'm practicing healthcare equity. And I really do think, as I mentioned, that medicine is going towards assessing the way that you achieve healthcare equity. And the reason I say that is that both the American Dental Association and the American Medical Association actually have strove to do this over the next couple of years. So here on the left, you'll see the ADA policy on teledentistry, where they highlight that they believe examinations performed using teledentistry should increase access to care by reducing the effect of distance barriers to care. This is a very clear statement on increasing healthcare equity by using teledentistry. Here on the right, you'll see a screenshot from the American Medical Association's 86-page recent strategic plan that they put out about embedding racial justice as well as advancing healthcare equity over the next number of years. And if you were to read this document and specifically look at how they recommend that you increase healthcare equity, you'll see that the recommendation is to implement specifically digital health and telemedicine services to patients. So again, I truly think over the next number of years, not implementing these type of options for patients will result in significant changes in the way that you're able to see these patients and get reimbursed for care and how your practice will be evaluated. Now, I know many of you are thinking so far, this is all well and good. It's very nice to think about the equity of healthcare, but how would I go about implementing this in my practice, particularly if you say there are different regulations and legislation state by state? What is the time, effort, and finances required to actually implement this? So let's take a step back and talk a little bit about saving time and money with introducing intraoral telehealth into your practice. And then we'll give you some examples of how I have used this in my practice to save myself time and money. Again, in my case, specifically using the TelScope device. So I want to start this conversation by bringing up an old aphorism that many of us are very familiar with. And that's an aphorism that was attributed to Ben Franklin in 1784. And that's the aphorism, time is money. And many of you may know that this was actually attributed to an essay that he wrote that was titled Advice to the Young Tradesman back in the 18th century. And this is an excerpt from that letter where Benjamin Franklin says, "Now remember that time is money. He that can earn 10 shillings a day by his labor and goes abroad or sits idle for the rest of the day, though he spends but sixpence during his idleness, ought not to reckon that, and that is the sixpence, the only expense. He has really spent, or rather thrown away, 5 shillings besides." And when I think about this, I really think this encapsulates very well the way healthcare in general is going with regard to looking at efficiency. This really highlights to me the innate relationship, really the innate interchangeability between time and money and how this affects healthcare. And I will tell you, if you look at private corporations and those of you that are involved in corporate dentistry and corporate medicine, really healthcare in the USA has moved towards what I would call incentivized efficiency, meaning that looking at every way to maximize your time throughout your day and throughout your week to increase the care that you perceive that you give to patients, at the same time saving yourself time and money. And so for those of you that work in corporate settings or have worked in a hospital setting before, you can probably understand that in large healthcare systems in the US, the best example of this is actually in the operating room. And this is because in major health in academic medical centers today, up to 40% of the healthcare system's revenue comes from efficient running of time in the operating room. So, for example, in my institution, when we look at our numbers, this is a sheet that we look at every single week. We look at the amount of time by staff, by surgeons, and by hospital administrators. We look at our cases and our procedures we perform. How long does it take me to perform a procedure? What if we look at the time from inside the room to when we leave to recovery? How did the scheduler schedule that time? What about our electronic medical record? And what model can we make that will better incentivize us to use our time efficiently? And really, this is how intraoral telehealth can improve your practice with adding an efficiency that you and your patients can enjoy. And many of you may look at this and think this is somewhat of a depersonalized way of looking at healthcare, looking at time and efficiency. But I will tell you, this is being used across the board, and that is in no way made more clear by the fact that this is being used nowadays in cancer care. So this is an article from the Journal of Clinical Oncology just a number of years ago. This is one of the preeminent journals in the United States, titled "Time is Money, Optimizing the Scheduling of Nivolumab." And you may be surprised to hear that this study actually talked about nivolumab. This is a medicine and immunotherapy that's used for head and neck cancer and also used for lung cancer as well as other cancers. And this was a charge by the FDA commissioner, who was Scott Gottlieb at this time, to try to improve healthcare costs by decreasing costs, but at the same time improving or at least keeping the same our patient outcomes. And long story short, they were able to find that if they decreased the dosing of a certain medication, this nivolumab, from once every 2 weeks to once every 4 weeks, saving that clinic time for the patients, the time in infusion, the time in laboratory work, they could actually save significant healthcare dollars, and the patient outcomes were exactly the same. It kept everything exactly as it should be. No patients were harmed as far as worst outcomes. And I'll tell you, this, if anything, should show you that if we're doing this in cancer care, we're not using incentivized efficiency as an exchange for patient outcomes. We're actually using it as a way to achieve what we call synergism or mutualism or even commensalism in healthcare. Now, some of you may recognize those words from Biology 101, but let me show you how I feel that intraoral telehealth can actually achieve what we'd call mutualism in your outcomes for you and your patients in saving time and money. So if we perform any intervention, in this case, we're going to use intraoral telehealth, in my case, again, the TelScope system, and you were to achieve a synergistic relationship with this, that would mean both you and your patients would have exponential results from this. Now, this doesn't occur much in healthcare. This would mean that your patients had exponentially good outcomes or satisfaction, and you had exponentially increased money from a simple intervention. Usually when we talk about synergism, someone's talking about a chemistry lab where you add two things together and then you get a significantly increased product that's more than the sum of its parts. But I will tell you, I do feel like in my practice, when I introduce intraoral telehealth, I can achieve what we'd call healthcare mutualism. That means by this intervention, I can improve patient outcomes, I can improve patient satisfaction, patients save their time and money, not coming to see me in person as often as they otherwise would have to do. And at the same time, I can maximize my time, save money, and make more money by seeing patients in the office that I need to see in the office and seeing patients through oral telehealth that I can see in that way. As many of you know, depending upon what your background is, there are certain things that we do make money on and certain things that we don't. And we need to find a way to do all of them. New patient consults, at least complex ones, oftentimes need to occur in the office. Procedures are big money makers and need to occur in the office. Follow-up visits, surveillance visits, post-op visits, patient check-ins, they can occur in the office, but many times this requires much cost and time and effort on both ends. And using these visits as telehealth visits, as I'll show you how I do in a moment, can save significant time, effort, and money on both ends. Now, at the worst, an intervention like intraoral telehealth should result in commensalism. This means that if I use telehealth, maybe my patient has benefits from it, and I don't have any benefits. I also don't make any money or lose any money or time. Or at the very worst, this is what occurred in the nivolumab study that I just highlighted in cancer care. The patient outcome is exactly the same, but the healthcare system saves time and money. Again, I truly think that you can get a mutual outcome for you and your patients from using this. And so this is how I have approached intraoral telehealth. Again, specifically in my case, using the TelScope system, I asked the question, how can I use teledentistry and telehealth to benefit my practice? And I have found this mutualism to be very easily successful. So let me show you a couple of options as far as things that I do in my practice. And then we'll talk in just a moment some options for patients and providers that may be in dental environments or in more medical environments. For those of you who may or may not have looked at my background, I have a background in both dentistry and medicine. I'm an oral and maxillofacial surgeon by training and also have training in head and neck oncologic surgery. So I have an interest in head and neck pathology. So I use the intraoral telehealth option with the TelScope device for remote cancer monitoring and precancerous lesions. Many of you know these as oral potentially malignant lesions or oral potentially malignant disorders. Now, I'm not saying that I don't see any of my patients in person. I always still see them for surveillance in person, but I am saying that many times these visits, at least some of them, can be substituted for intraoral telehealth visits. So, for example, due to patient factors, a patient is sick, a patient has significant comorbidities, a patient has a family member that requires care, or even if a patient has a new concern between scheduled visits with me, we can very easily perform an intraoral telehealth visit. And I will tell you, as you will see with the demonstration at the end of this presentation, with the TelScope device in particular, the image quality is spectacular, such that I feel very confident when these patients are using them at home, or if a rural clinic where this patient goes far away from my academic medical center uses this on the patient and transfers those images, I feel very confident that I'm actually seeing what I would be if I saw this patient in clinic. I also use this for postoperative monitoring. So be this a large operating room procedure or a very small clinic procedure, many patients don't require routine follow-up. Those patients can either be provided a TelScope device, or again, if they live far away from your location, in my case, my medical center, they can go to a rural health clinic where they live close to for postoperative images. If they have a question that comes up, those can be transferred to me and I can correctly direct the patient to see if I can reassure them if they need to come to see me, or if I can direct them to a community care physician or dentist closer to them. And then lastly, something I use extraordinarily frequently is also other types of recurrent or chronic lesion monitoring. For people in the dental or oral medicine field, think lichen planus, recurrent aphthous stomatitis, thrush, or infection resolution. So many times patients come in for evaluations, they require an antibiotic. They don't necessarily need to come back and see you in a clinic visit for a follow-up, but maybe a telehealth visit would help to reassure you and the patient that things are resolving. Again, this all revolves around what is most beneficial to you and the patient, thinking about what cases need to be seen in your clinic. We all know, again, post-operative visits, you're not making money. The patients a lot of times are coming way out of their way for these. These can be done at home in many cases. And again, as you'll see with our demonstration at the end, these image quality that I can get with the TelScope device reassures me that actually what I'm seeing with intraoral telehealth is exactly what I would be seeing in clinic. So I'll briefly talk a little bit about reimbursement. I know, again, I like to talk about how this can be used, as I just described, even in the setting of if your state does not have the same reimbursement of another state. But let's talk briefly about it. So for those of you that have more experience than me or the same as me, these will be very familiar with you, but some of you may not know these. So in general, there are a couple of teledentistry codes for CDT, dental coding, that are used in combination with other codes for teledentistry reimbursement if your state so allows. And that is D9995 and D9996. And these are, as I mentioned, coded with the other codes that normally would be coded. So a post-operative visit or a limited evaluation, for example. Now, synchronous and asynchronous dentistry means synchronously seeing a patient and discussing two-way over a video conversation, for example, versus asynchronously. Let's say that a patient goes to a rural health clinic, is seen by a physician or a dentist there, some radiographs are taken, intraoral images are taken, and those are sent over to you, at which time you review those, review notes, and then make a treatment decision. That would be asynchronous teledentistry. And here's the kicker for this, if you don't use this, is that the ADA's policy on this very clearly states that when you perform examinations and interventions using teledentistry, all of these must be based upon the same level of information that would be available in an in-person environment. Again, I see no better way in my practice of actually getting the intraoral crystal clear images and illumination than with the TelScope device. And this allows me to feel confident that I'm following the guidelines here for the teledentistry implications of the American Dental Association. So this helps to answer the first question we talked about. If my state allows teledentistry, how might I get reimbursed for some of those services? And again, I would implore you to look at your state regulations, as they are quite various across the states, and many of them are quite new, as I mentioned, in my own state of North Carolina. Now, for those of you that bill CPT coding or medical coding, there are options for telehealth as well. And you should be aware, if you don't, and you do CPT coding, that as of just last year, the coding completely changed for how we can get reimbursed for services. Before, we could only charge for face-to-face time. So if a patient came into my clinic and I examined them and talked to them in person, that was the only time in medical complexity that I could get reimbursed for. Whereas as of last year, all the time spent on patient care activities that day are reimbursable. So for example, if I see a patient in my clinic, I use my TelScope to take photographs. Even when the patient has left behind the scenes, if I'm uploading those images, if I am sharing those images to a patient's primary care provider, dentist, pathologist, or other specialist, all of that time and effort and complexity that I put into the visit, I can now code for under the new changes as of last year. So I want to give you a couple of extended use cases, and I'm really passionate about these. Many of you may not be involved in many of these areas of medical or dental care, but we have really explored how to use oral telehealth across barriers and across specialties. So I work with a lot of dermatologists and rheumatologists, as well as other specialists, and it's very nice to use telehealth. And in my case, again, specifically the TelScope system is what I use to coordinate and collaborate with these individuals. So many of you know that many oral manifestations of systemic disease track with disease severity and control. So in endocrinology, the degree of control of one's A1C in diabetes tracks very well with periodontal disease. Images can be shared between the dentist and the endocrinologist or the specialist. I work with a ton of rheumatologists. We follow maximum incisal opening and jaw deviation through images and through documentation for patients that have systemic arthritis, rheumatoid arthritis, psoriatic arthritis, juvenile idiopathic arthritis, etc. As you know, with dermatology too, many of these cutaneous diseases have similar oral manifestations. We talked about lichen planus before. Very frequently, we share images from one specialty to the other. This can also be used in the inpatient setting. For those of you that may have some association with a hospital critical care unit, You know that many tubes and drains and other things occur in the oral cavity when these patients are critically ill. There are endotracheal tubes, orogastric tubes, all these other things. And we have very standardized protocols to care for the oral cavity in these critically injured patients. That is chlorhexidine swabs of some frequency. But until the TelScope device, I didn't really have a good way to document this. And so what we're able to do now using this is document the oral condition, document lacerations in our trauma patients, and document oral care measures that are performed. And then one that I'm really excited about is the implementation in anesthesia care. So as many of you know, in medical centers, if you've had outpatient procedures even, anesthesiologists usually perform a head, neck, and an oral pharyngeal exam, a throat exam, to try to stratify patients for risk of intubation difficulties or difficulties with ventilating patients. And by using the TelScope, our team is actually able to more objectively document this in the record. And this way, it's not simply documenting a score as we've done in the past, but we can actually look at an image that someone else took. And when a different anesthesiologist sees this patient, there's some continuity with these standardized images. We've also talked about using this in our hyperbaric unit, as well as our sleep medicine units as well. Looking more on the dental side and the oral care, I mentioned about my passion for oral pathology and cancer. This can be used, of course, by anybody, dentist, primary care physician, etc., for documenting oral lesions. Many of these, even if they're not oral, potentially malignant lesions, the images, as you will see, are fantastic with this system and used as standardized documentation. Communication across providers. Again, when we're talking about asynchronous reimbursement for dental procedures, if you communicate with specialists or general dentists and they send you images taken by the patient or a rural facility of that patient sent across geographic borders, you then see radiographs that outside provider took, you can perform and get reimbursed for asynchronous telehealth visits. And then lastly, something that many don't think of, but actually becomes quite handy, is communication with pathologists. Pathologists very much require images to make accurate diagnoses sometimes. And in these patients that have biopsies in rural clinics, many times the pathology specimen is still sent to an academic medical institution. And so if these rural clinics have the TelScope device to take this image, that can be sent to the academic pathologist hours away, at which time it can be evaluated and used to secure the diagnosis. So I want to come back to this image in this video that I showed you before of this patient who was diagnosed with a squamous cell carcinoma. This was actually a patient, as I mentioned, in rural Australia who came in after a lingering cough. The general practitioner used the TelScope device to illuminate the throat, identify this abnormal mass, and this individual was sent to a specialist to undergo further treatment. And this, of course, ended up being something that required quite urgent care, and that was achieved for this patient. I want to highlight real briefly before I give the floor over to Mike. I think Mike's on the call as far as doing our demonstration tonight about the three-step system for the TelScope system. So this system, we kind of split up into an examine, capture, and connect. By examining here, we use the TelScope device, including the illuminated single-use tongue blades, to examine the oral cavity in the throat. Again, you'll see how the illumination and the images really come crystal clear. You can then connect this to your smart device, be that a tablet or a smartphone, and then that is used to capture these images. And then, of course, those images can be shipped out from a patient to a provider, from a provider to another provider, or of course stored in the medical record for later documentation. So let me go ahead and finalize my portion of our presentation. I thank you all for your attention here, and I will get to our questions as well once we allow Mike to do our demonstration. Mike, I'm going to go ahead and stop sharing, and I'm going to make sure that you're able to share, and hopefully you can take it away for us. Give us just a second.
All right. Well, thank you very much, Ben. That was fantastic. Appreciate everyone's time tonight. And in essence of being able to stay within the hour, I'll try to be as quick as possible. But basically, the TelScope is a very easy system to use. It's basically made up of a handle that is rechargeable. It's antimicrobial, and it is on 2.5 hours on a charge. And then it uses these single-use blades where the unit only illuminates when you actually connect the blade. And then also, this is where you get the great illumination. So now I'm going to go ahead and grab my phone and start the broadcast and take a couple of images for you. So Ben, what images do you typically see when you're seeing like a remote patient and looking at images that they take with the TelScope system?
So let's start with the throat, since that really highlights to the illumination, and then we'll move on to floor of mouth and side of tongue. Have a nice tongue tie there, Mike. And then of course, if you wish to take some dental images as well.
Okay, we do that as well.
Yeah, perfect.
Oops. Okay, so what I'm going to do now is I'm just going to show you really quickly. So the button on the right is for video. The button in the middle is for the stills, and then the button to the left where the 7 is, that's where all the images reside. So I'm going to go in and show you the images that I just took. So as you can see, the one to the upper left says current, and it's also timestamped. You can actually go in where it says 1835, this is military time. There's a little crayon there. You can actually hit that crayon, and if you have, say you're in a remote location and you have a number of patients you're going to see during the day, and you want to make sure that you remember who's who, because each set would be each patient. So you could actually erase the timestamp and add an identifier like the patient's charting information, and then that would be identifying these images that I just took. So I'm just going to go into one of the images. So let's just do the front of the tongue. So you can actually zoom in, zoom out. You have the ability to, so like for example, I have a tongue tie, circle the area of concern. You can actually measure that area and then also annotate. And then this is where Ben can get the images. So actually what on the upper left there's or in the lower left, there's an up arrow, and you just hit share secure zip. And then actually I can share these images with Ben with the 6-digit code for compliance for HIPAA. And I'll just send those off. And the 6-digit code is changed every time you create a new set of images, you create a new 6-digit code. Now, one thing for dental, you have the ability to create sets. So you can actually create like for a patient file, so you can actually set a template, either general dental or general throat. So I'm just going to go general dental. So you have the ability to create these images into a template in order, and then be able to email them off if you're, triaging a patient remotely. If you're, like geriatric, working with geriatric patients, or you're even in the hospital setting. If Ben needs certain images, you can create a template to be able to send those images over and be more, ready to be able to make a better diagnosis. So the other thing too is I took a video a little earlier. I'm just going to show you that as well, because it has 30 seconds of video capability. Just have to remember where I put it. There it is. And you also can take stills from the video. So if you have a patient that is having a hard time hitting the mark, you can take a video and then take stills, because in the button, there's a button in the upper left. You can take stills from that video.
You can also do it if the provider isn't hitting the mark, Mike. I use that a lot.
Oh, okay, great. That's great. Um, Ben, did I cover it? Is there anything else that I missed there?
I think that's great, Mike. That really highlights, like I said, kind of the images that can be obtained. And as I mentioned, for me, that's what one of the best parts of this is that those images that are obtained, I really feel like I can go by those. So, well, I know there are a few questions, and I know Casey's been fielding some of those. Let me just kind of see what we've got, and feel free to answer any more. Let me just see here. Yeah, I saw what you said, Steve. That's exactly right. The Dental Informatics Subcommittee, as far as standards for this in the future with AI and AR and such. And so I think this is a very exciting topic. This is something that we've talked about as well, just in discussions on the side, as far as, what will be the next step as far as AR and AI with all of this. And I think this really opens up doors to some exciting avenues in the future. And then it looks like Caroline there as well. Yeah, asking when I got started, what did I start with as far as these use cases and build from there. So as I mentioned, my area of interest is oral pathology, and I follow a lot of oral potentially malignant lesions or oral potentially malignant disorders. And so that's where I started, was patients that I had seen for a consultation. And so I felt confident when I was first starting to use this, that I kind of knew what I was starting with. Because it's normal, of course, to have some hesitation to start something where you're going to be looking at things in a slightly different way, and then implementing that for those patients. And again, I think what is very nice is, even if you are following certain patients and you're someone that monitors lesions, normally you will do some of these in clinic, but for many patients, and even for particular patients, if they live next door, there may be times where they don't have this option. So I did start with a specific use case, in my case, oral potentially malignant lesions, and then kind of jumped from there. And as you saw, actually at Duke, we've had a lot of discussions about medical use cases as well as dental use cases. So let me just keep going down. So Lori asked, does it matter which type of phone and how do you focus? And Mike, I know you're still on here too, so feel free to jump in. You can use various types of phones. It depends upon, of course, the case that you have. You have to apply the adhesive to the actual back of the phone such that the blade is placed in the correct location, so that actually it auto focuses and gets you these perfect images. It's similar to some other, way in the past, there were some devices too that you would use when phone cases first started coming out. And there's a way to apply this to your phone case that makes sure that the blade is in the correct location for illumination and for automatic focus in the oral cavity. But that's a great question, because obviously when taking normal photographs, which I still do occasionally, depending upon the situation, the focus becomes a huge issue for me with the normal camera, as it really doesn't with the TelScope. Mike, were you going to say anything on that?
Yeah. Regarding the phone or the smart device, actually, the better the phone camera, the better the image. So, like the images that I just took, that was a 11 Pro. But anything like 10 and above, as far as iPhones are concerned. And then also your question regarding the app, the app actually sets the zoom level perfectly to be able to get great images inside the mouth. So that actually is something that the person that's using the device does not need to worry about, because it's already preset. The other thing too is that you're able to maneuver inside the mouth with the blade, and with the blade's lighting the way it is, that's how you get the great images. And like I said, for phone cases, we do have phone cases for a number of the different smart devices that are out there, but there are a lot of them. So we do provide a link inside the TelScope, a little card that shows you how to put the little clip, which looks like this, on the back of the phone in the proper spot to be able to get the great images. Does that answer your question?
Yeah, hopefully it does. If not, Lori, give us a follow-up in the chat.
Or we can always, you can get on a demo with me, because Casey can provide the demo link as well.
And then Catherine asked a really good question, which is a question that comes up a lot. And actually it comes up with telehealth in general.
which is PHI, personal health information, and that being transmitted. And the specific question here is capturing PHI or potential PHI on a personal smartphone and putting one at risk of HIPAA. So the beauty of using this in an intraoral or a oral pharyngeal or throat environment is that by definition, if you do not put patient information with that, as far as a patient's name or date of birth, etc., intraoral images and throat images are by definition de-identified. So if you take these with your phone and then put some type of tag, patient number 1 that you saw in clinic, that is not breaking any HIPAA issues. If you were, you're right. If you were to take photos of patients and then put their name in there on your personal phone versus transferring that to the medical record first, then you potentially would be breaking HIPAA. But no, just luckily capturing intraoral images and throat images, by definition, those images are de-identified. Jonathan asked, how does an individual on their own use the device given they can't see the display on the tablet screen? And that's a very good point. So that kind of goes to when you use certain smart devices, as far as using a tablet, which we sometimes use in a clinical setting, versus a phone for a personal setting. There's a couple options for that. And then Mike, feel free to give your thoughts as well if you wish. One is, of course, if you are with someone, many times if you think about it at home, people do like oral examinations on themselves anyway. Hey, honey, can you look at this? You can have your friend, your spouse, whomever snap it for you. The other is you can become quite facile, exactly as Mike's showing. You can become quite facile with a hand mirror or a wall mirror with this. I know when I first was using this and trying out the application way back when, that's what I did on myself just to get used to it. And it becomes quite easy once you use it for an extraordinarily short period of time.
I'm not a medical professional at all, and I learned how to use this product in about 10 minutes just playing around with it, because you're actually, if you use a mirror, you'll be able to see your mouth, and you'll be able to see exactly where you are. Or if you're using it on another patient, you'll be able to see where you are because you're looking right at the app. So you use the app as your guide.
Perfect. Well, if any more questions, I'm happy to entertain them. I know Casey's put a couple of bits of information in the chat as well, as far as if you'd like to schedule a one-on-one demonstration, there's a link for that. Then she also, it looks like, put in here a link for one of the head and neck screening kits that has been developed, that of course includes the device, and then also a head and neck oral screening examination, the exact type of examination, for example, that I used. And then Catherine has a question here. Is the app cloud-based, or are those images stored locally on the phone itself? And I think Rick actually had commented a little bit on that above. So the images are initially stored in the application itself. And as Mike showed you, you can send them through a zip file securely. You can also, the patient, for example, if the patient is using this, you may have seen when Mike was doing that, they have the option to then transfer it from the app onto their photo reel. But it is stored initially when the patient or provider takes it in the application on that phone locally. It does not go to some cloud where then someone else would potentially have access to it immediately.